Hello, I am Ferran Llansana, specialist in dental aesthetics and oral rehabilitation, and my dedication is exclusive in Palma de Mallorca to aesthetics and rehabilitation on implants with digital workflow. And I have the pleasure to be here with Carlos.
I am Carlos Plata. I come from Seville. I am Technical Director of Laboratorios Plata in Seville. We went digital in 2010, and nowadays we are very specialized in digital workflow, dental aesthetics and on implants, but above all based on a completely digital flow. Let's start by talking about the contribution of scan transfer to the restoration on arches. It's a bit of a new concept, but there's a reason for everything. Until now we have seen that we could scan intraorally, but we didn't really know how accurate we could be with intraoral scanners. Well, thanks to this study that was done by the University of Zurich, we learned to differentiate between what is accuracy, what is reality, and when we put the two concepts together, we get accuracy. There may be intraoral scanners that are precise, others that get reality, but maybe between them we don't get a lot of accuracy. So let's explain what is the concept of each one. Accuracy is that the dots are all close together, they are not scattered, but they can be centered in the place where they should be. And the reality would be when they are all centered in the point that should be as a target. When we manage to unify the two and unify precision and reality, we get the points grouped in the specific place, and so we get the accuracy. This is what is really going to affect us when performing an intraoral scan. The scan transfer design is going to be crucial for that, because it is going to help the scanners achieve that accuracy better. So that we can see as well the difference between one scanner and another. There are those with more correlation points for image quality, those with less correlation points. And the key is that the more correlation points there are, the more chances we have to make a good match from one image to the next. Because we are going to be flowing an intraoral scan, and if we have fewer points, the correlation from one image to the next is going to be more inaccurate. That is why the quality of the dots of an intraoral scanner is important. Also according to the depth of capture that they may have, or according to the technology they have. In this case, it has been compared with the dynamic lens. If we have a fixed position and we have different anatomy, that can make that by having different depths of light, we do not have a reality on the surface. However, if we have the possibility of capturing different depths, we will have a more realistic surface. This will also affect the accuracy of the scan body and the accuracy of the future restoration. And also, thanks to that number of points and that reality, if we have an image in the next one that coincides more in points and in that depth, we are going to get the software to be able to match correctly between one image and the next. If we start at one end of the arc, we end up at the next end. Either we are correlating points correctly, or we are correlating points incorrectly. And that will affect whether we end up with an accurate arch or not. Intraoral scanner technology is fundamental. That is why we want to explain the difference, so that we know that it is not the same to start designing an arch, or even a bridge, with one type of intraoral scanner or another. In fact, there are integral scanners that tell you this is for 3 pieces, this is for half arches, this is for full arches, and they have different levels of intraoral scanners, because that is going to affect our image quite a bit. That's why the University of Zurich did this in vitro effect. I'm going to tell you a little bit about how it went. A model, an STL with an intraoral scanner, and from there it was scanned with all the intraoral scanners that were on the market at that time. With a robotic arm, because another factor is the human arm. If it is scanned by different people, or even the same person, different models with different scanners, that is going to vary. So it was important to have a robotic arm repeating the movement exactly the same from one to the other. And we got this result where we were talking about precision and reality. And we had the different scanners, and we can find that some, for example, is very good in precision but is bad in reality. Another one is better in reality and worse in accuracy. The one we were talking about before, which is the one Ferran has, the prime scan, we got good accuracy and reality data. It is important to know all these factors, to know if the scanner we are using is giving us the accuracy we need to know, if it is giving us the accuracy we need to do larger jobs or not. Not all scan bodies are the same. If here we have, as Ferran explained before, the IPD scan bodies, in this case we have the 10 and 15 unit ones, but the shape of the scan body will favor that it can be recorded with more or less hand movements. The more we tilt and the more movement there is, the more inaccuracies we will add, because the more different planes we will be adding within the same scan. That's why not all scan bodies are the same, and hence the importance of scan transfer. We have a head that, because it has a slightly conical effect, passing through occlusal, we can already take the occlusal part and the contour part, and from there, having that information when we are rotating, we will be adding to that initial scan. As there is less movement, we will have less errors due to arm inclination. And that is the most innovative thing about scan transfer, in addition to all the other advantages it can have when making a prosthesis.
Very good explanation. Less influence of the operator, because in the end it doesn't influence so much how he scans. That's the goal, to limit error to a minimum. Limit human error, always. So this slide, what we see here is that we go from the print copying that we have described in the previous video to the scan body that we've also described, and you see the difference that it has. One has a retentive capacity so that the silicone stays with us. It is the impression copy of a lifetime, and the other one is not the other one. What have we achieved with the scan transfer? We have achieved a mix between the retentive design, which would be this black part that we see that is totally retentive, which is going to give us an advantage that we will also see Carlos, and the scannable part, which is the upper part, which we are going to call only top, for the only top technique, because we only need this upper scanning part. So why this retention? Because we have had many problems with different scanners. We haven't talked about this, Carlos, but you will agree with me that there are different scanners, different brands, and the head is very different in all of them. So there is a contradiction, and it is that in the mouth, the smaller the scanner, the more comfortable it is for the patient, but at the matching level, which you have explained very well. The bigger the pickup, the less matching or stitching you have to do to make the image of the complete arch.
Because each individual image is going to be bigger, and we are not going to have to join so many images, but maybe if in an arc, we had to have 8 overlaps. To have the complexity of the arc, maybe with a larger scanner, 5 or 6 will be enough.
Then we reduce the coupling error or stitching. There are also many articles. Let's go into the literature. What were they doing? They were trying to stitch the scan bodies together. Why? Because the machine, you have tried a scanner that goes crazy. It doesn't differentiate between a scan body and another one from the other side, and the machine goes crazy. So different articles comparing how to join these scan bodies to reduce the error in different methods, flossing. There are many articles here that you will see. Splinting them in a way that a plain scan bodies to splint is complex. Making impressions and then being able to make them come out as a single tray. There are different systems, as you see here. And from here comes the scan transfer. We change this smooth anatomy by an anatomy that will help us not to lose the intraoral scan, because the scan body are all the same and the scanner cannot differentiate. It is different when there are teeth in the mouth. Even if you have 4 teeth, it detects them differently. And when you scan again, it will tell you this is the lateral, this is the 7. A scan body doesn't know if it's the one in position 12, 17, 22, and it goes crazy. This is where the scan transfer helps us. Another very important thing is that we see here the scan transfer. In addition to the X-ray, we can see that if the screw comes out on top, it means that it has not been adjusted perfectly. If the screw is flush, it means that it has screwed correctly on the multi-unit. And here's what we were talking about. It makes scanning easier. We splint in the mouth with a bit of dental floss and see how easy it scans. It does not get lost. With one pass, as Carlos said, it captures all the superficial part the first time. In fact, the first image is always the good one. A smooth scanning workflow, coordinated without many jumps. And notice that at the end, with one pass, now we make the second one more occlusal. I always like to start with palatal because the arch is shorter, so it will give you a better implant position with less stitching, and then you go occlusally to define the surface and the ideal position in the laboratory of the case.
How long can it take in real time? 1 minute?
Less than a minute. This is in real time. Look, I don't know. 30 seconds, 35 seconds. Pretty fast stuff.
To compare to an analog impression taking with time, with like 7 minutes in the patient's mouth.
7 minutes in the patient's mouth, uncomfortable, not being able to know if we have done it right or not. Because until you empty it, we don't see it. We already see the capacity. Here we are going to show you the video of the company where he explains the position in detail. Look at the adjustment, what we were saying about the screw, the asymmetry from the plane, which makes it easier to scan. As Carlos has said very well, the retentive zone that makes very well the facility to make this retention. And what we commented to have clear if adjusted, if the scan transfer has sat well or not. Now we will see this is the rendering. We are going to see it in clinical cases of how we managed to do it. This is the case. We see a case where we splint first. I like to put a base with a resin liquid dam to bond what you could put dental floss on, but this is faster.
And in case anyone is concerned, there are also the caps, so as not to stain the top of the scan body, which is the scannable part. Because if we get to put resin on the part that is used for correlating, we can have digital problems later on when correlating. That is why it has the cap to cover the scannable part, so that it is not modified by the resin.
Exactly. Another important thing, we have done the digital scanning. We know that printed models, many times the reliability is not as high as we would like. So, we can do the dragging of this fertilized technique and cast it with a conventional plaster model, or even passivizer base, as we will see later. Indeed, if we had to choose the gold standard of the printing of a lifetime, it has always been to make a metal framework that is, as is the article by Marta Revilla here, a synthesized metal framework is made, and there, as they used to do with plaster, effectively, well, that's where we continue, we splint it and drag it. That would be the conventional and the best thing to do, right? This transfer to scan transfer, as we see here, we can do the same thing. We take a scanner, we do the metal framework, and from there, with the minimum shrinkage, we make the digital impression. And at the same time, we make the analog model. We see here that we can make the scan where we will design the bar and we will have a physical model. Here is the dragging with the technique that we have described.
We can also use the splinting even of digital matching to correlate a model with the digital one in the laboratory.
Exactly. But we see that with this technique and the prime scan, we can achieve the same result as you will show later. So we make the structure. Why do we want a model here, a physical model? Because in this case, we are going to do a restoration, a hybrid, and we could do it printed, but many times the technician prefers the model with the gypsum for the resin. It's not zirconia.
And there are also times when, as we will see later, using different materials, maybe we need to have an analog model to do a composite-based finishing, or to have axis tracking with the antagonist. And even though we can have it also in the digital, we move to some analog phase for manual completions, for example, composite or ceramic.
But the work, the bar, has been made digital. That is, it has not been done otherwise. Then we see the fit, perfect with the Sheffield test. And this is the resin, the finished case before and after. Here you see the hybrid.